In So we already 23 participants. Should we, it's 3 or 5? Do we give them more, do we give more people some few minutes to join, or can we proceed and they will find us on the way? Maybe I would appreciate your suggestions.
Hi, Gary. I think they would find us on the way. Considering it's a Friday, we don't want to keep people waiting for so long.
Okay, sure. So I'll invite Marietta to give us an opening remark, and then we can proceed. Thank you, Marietta.
Hi, everyone. I hope you can hear me well.
Yes, Marietta, we can hear you.
Beautiful. Awesome. Hi, everyone. Thank you so much for making time on a Friday. I know this is not everyone's favorite time. Yeah, thank you for having me and for giving me the opportunity to open the webinar today on men's health. So dear colleagues from the UN family, representatives and friends from civil society and from men's organizations, from key population organizations, and especially from young people's organizations from across the SR region. Especially a hello to the co-organizers. Thank you so much for setting this up today. So today is the International Day of Elimination of Violence Against Women, which I'm sure most of us, or probably all of us, are well aware of. But it's also the beginning of the 16 Days Against Gender-Based Violence, and World AIDS Day is around the corner. So with this very crowded space of many international days right now, why put men's health in the focus? So first of all, I want to say that first, men can be perpetrators and victims of gender-based violence, and especially men in the diversity and belonging to key populations are on the vulnerable side. So for example, gay men and men who have sex with men have 6 times the chance of new HIV infections compared to heterosexual men and those who don't have sex with men. And while it's been said before many times, I apologize, AIDS prevalence has a woman's face, but AIDS mortality has the face of a man. So this is still very important because it shows us that we are not making the progress on men's health like we have done luckily on women's health. We know that over half of young men aged 24 to 35 living with HIV are unaware of their status and are not on treatment. We also know that those men who should be on ARVs are 70% more likely to die than women because of poor adherence and poor health-seeking behavior. So as much as the quote is getting old, more attention is needed on the matter, and I'm really grateful that we are setting up this, that we're putting a bigger focus through setting up this webinar today, so that we can curb the numbers for men as well. So, and additionally, of course, we are talking about men here, and improving health of men, but it's also that men have the power and the position to create healthier and safer communities if they are able and willing to access health services better. I do want to mention that earlier this year, we as UNAIDS have published the male engagement framework in HIV for the SR region, and many of you have been there online, so this might not be completely new. So the framework has found 2 main aspects that contribute to the poor status of male health in the region. One is social barriers, so it's prevailing harmful norms of masculinity that are a key factor that contribute to the large disparity between male and female health. It's a toxic gender norms that equate illness with weakness and that consider sexual and reproductive health a female issue, which leads to poor health-seeking behavior among men. And the second main aspect the framework has found is structural barriers. So how are health services structured? How are they accessible? How easy do we make it for men to incorporate accessing health services into their daily lives? So I like to say the framework was a good start. And I'm really proud to say that we've launched it multiple times on national level. It's guiding various national strategy development processes right now across the region. So this this is good. This is a good start, but it still shows us the huge gaps in the HIV response, and HIV response being part of the broader SRHR response and work, of course. At the beginning, I mentioned that World AIDS Day is coming up, and I want to point out the connection between the World AIDS Day and male health, because our theme as UNAIDS for this year, 2022, is equalize. And there are two main aspects that are specifically relevant, because without these aspects, we won't be able to make the desired progress on male health. So first of all, we need to guarantee human rights. There's no progress without a rights-based approach. I mentioned key populations and men and boys in their diversity earlier on. And in our region, only 8 countries have decriminalized same-sex sexual relationships. And even in those countries, stigma and exclusion remain very high, often denying members of those populations from their basic rights, which means keeping men and boys in their diversity from accessing healthcare and from accessing their rights. This is one element that I really want to stress. The other one is we need to equalize access to best medicines, because in our region, a lot of the long-acting prevention options that are available in developed countries are not available. And this is something that we need to shift and change in order for men to access healthcare and to be able to take care of them with the best technologies. So this is all from me today. Thank you so much for being here again. I hope that the research we are learning about today, the gaps that it shows, that it really helps us get ready for next year. I know a lot of us are in the planning process for next year. So yeah, let's get inspired, and thank you again for everyone who contributed to making this happen today. I'm wishing all of us a fruitful webinar. Thank you. Over to you again.
Thank you very much, Marietta, for joining and for giving us wonderful opening remarks. I would love to once again invite everyone to this session, and just some few housekeeping. Please ensure that you keep your microphones on off or on mute if you're not speaking. Please allow me to request you to raise your hand when you want to comment or ask questions, or also you may feel free to write your question or your concern or your suggestion in the chat box. We also encourage you to use the chat box for any questions or comments. And we also advise you to switch off your cameras to increase the internet bandwidth, especially for some of us who are in places where internet is not really friendly. And also remember that this is a voluntary participation webinar, so feel free to, if you feel like you want to leave or you're not comfortable to continue with the conversation, please just feel free to leave without interrupting the session. And we also encourage you to respect each other throughout the webinar. So I think already Marietta has just given us a background of why we are celebrating, or rather why we are having this webinar today. So thank you very much all for taking your time to join this conversation. And now I would love to invite our speakers so that they can introduce themselves and also give us some of the things that the research rather that they have been working on and some of the findings that they have. So I'll start with Kay. Kay, please unmute and take up.
Thank you. Good afternoon, colleagues, and lovely to be here on this Friday afternoon to participate in this exciting webinar, and look forward to engaging with you. My name is Kay Govender. I'm Research Director at HERD, and HERD is located at the University of KwaZulu-Natal in Durban, South Africa. Thank you.
Thank you very much, Kay. Maybe I can also introduce Sally, and then I'll give an opportunity to Kay to give us his findings. Sally? Sally, we can't hear you.
Can you hear me now?
Yes, welcome.
Okay, thank you. Sorry for that. My name is Sally Odunga. I'm a research officer at African Population and Health Research Center, which is a research institution engaged in conducting several research projects. I'm happy to join this webinar to be able to share some of the research findings of one of the research studies that we are currently doing. Thank you.
Thank you very much and welcome, Sally. At this point on time, I would like to invite Kemalin to give us his points. Welcome, Kay.
Thank you very much. I am loading up my presentation. Colleagues, I trust you can see this, the presentation.
Yes, we can see the presentation, Kay.
Okay, colleagues, I'm about ready to go, and thank you for coming to this this really insightful session this afternoon. And I note the comments made by Marietta on men, you know, that are kind of positioned in a sort of dualism as men as perpetrators and victims, and that's the complexity in dealing with men's health, and importantly, the theme that underlines the current conversation and the theme relates to equalize and the focus on human rights and access to best medicine. So in this afternoon's presentation, I'd like to take you through some research findings that we have undertaken with the support of UNFPA. It's a 5-country study, and we are looking at men's involvement in sexual and reproductive health and rights. The study is ongoing. And I can say that what's being reported in the study is empirical research. It's a piece of policy analysis that's been underway and in-country fieldwork. And the work is being conducted in 5 countries, namely Zambia, Zimbabwe, Malawi, Lesotho, and Uganda. And it focuses on a situational, or what we refer to as a rapid situation analysis of barriers and enablers to creating demand and also seeking SRH services amongst men aged 18 to 34 years old. As I've indicated, the study is supported by UNFPA and related agencies. And we've been conducting this research throughout 2022, and the data that's being presented in this afternoon is preliminary, and only part of the data is presented yet. There's some further analysis that's being undertaken at the moment. So just a brief note on the study team. It's a participatory approach to the work in the region, and we have colleagues in the 5 countries attached to relevant universities and a HER team that's also directing and guiding this research. So where are we in terms of men's health, or more broadly, sexual and reproductive health? We know that sexual and reproductive health is an essential component of the universal right to the highest attainable standard of physical, mental well-being, and SRH needs must be met for both men and women. However, we see, global, continental, and regional commitments such as the International Conference on Population Development Program of Action, Maputo Plan of Action, and regional static strategies, all emphasizing the importance of engaging men and boys to achieve gender equality and foster the empowerment of women, including addressing the specific social and health needs of men and boys themselves. We, however, know that despite these commitments, the current body of work in the Eastern and Southern Africa region indicates that initiatives to engage men and boys as clients or as users of health programs, as supportive partners, and as advocates of change in SRH remain small in scale. National strategies and policies pay insufficient attention to male-oriented needs and the promotion of gender equitable attitudes and behaviors amongst boys and men. The studies in the region indicate that more needs to be done to meet the sexual and reproductive health of boys and men in the region. Also know the important emphasis that neglecting men out of such efforts will ultimately lead to failure to improve the sexual outcomes, the sexual and reproductive outcomes of women and children. So, given that that short introduction, we go into the study, and the study aim was to undertake a rapid situational assessment of the environmental, social, and behavioral drivers that facilitate and impede uptake of SRH services. We focus on boys and men in a particular age range and across 5 countries. And more specifically, we wanted to undertake a policy review to get the status of the evidence on policy and programming in the region, undertake a survey of norms and behaviors and attitudes, look at access to SRH services, and then we were working towards integrating and synthesizing the empirical data to provide some directions for program strengthening in the region. It's important when we engage with boys and men for us to have a kind of theoretical lens to approach this work, and the life course approaches is key to this to the strategy here. And if you look on the horizontal axis, we're looking at a development of children into adulthood, and the transitional space between puberty and moving into adulthood is really important, because in this space you have risks, vulnerabilities, and also opportunities for increasing your diversity and adopting new identities. So that's an interesting space for understanding sexual and reproductive health. But we also know, as indicated on the vertical axis, that there are social determinants of health, there are mediators, risk and protective factors, which ultimately link to health outcomes, and this impacts on health behaviors of boys and young men. Importantly, within the SRH framework, there are 3 intersecting areas that we need to focus on. Men as partners, really important to engage with services in relation to their partners, men as clients, and as men, importantly, men as agents of social change. And these 3 intersecting areas are important to understand the drivers and the consequences of SRH health. In terms of programmatic strategies, the IPPF document indicates a number of areas where we should focus on men's health. And there's a sample of the areas in terms of the global package of services. And we have operationalized that in terms of survey items across the research work that we are undertaking. So the rapid situational assessment methodology, we undertook this in 2 phases. The first phase was a policy review, and the policy review looked at focusing on the strengths and weaknesses of current policies and strategies in each of the countries, including opportunities that exists to advocate for adolescent boys and young men sensitive approaches. We also undertook in-country research through surveys with men and boys in each of the countries, and qualitative research to focus on experiences of our sample in accessing services. We also interviewed program implementers, decision makers in each of the countries to get a perspective on programming. So in the early phase of the research, we undertook the policy analysis. And we also note that there has been previous work that's been undertaken in terms of a policy analysis. And Sonke Gender Justice in 2017 noted that no country in ESA had an explicit policy, strategy, operational plan for the involvement of men and boys. And they observed that men SRH needs were partially integrated into national health policies and programs. And this mostly pertained to HIV strategies, particularly VMMC. So that was where the focus occurred when there was policies that noted or mentioned men and boys. Globally, men's use of SRH services and commodities is significantly less than women, yet men have shared responsibilities for decisions around contraceptive, preventing STIs and HIV, or as parents and directing the health needs of their children. So SRH programs for men have been shown to reduce men's risk-taking behaviors. In terms of our review, we covered 8 regional commitment documents and 73 country documents within the scope of the review. And more specifically, we reviewed national laws and guidelines and policies, and we looked at the policies in terms of the global package of services that I've just indicated. We looked at non-clinical areas, and we also paid attention to the regional strategies, the SADC regional strategy, the HIV declarations, Maputo Plan of Action, the Africa Health Strategy, Abuja Declaration, Comprehensive Sexuality Education, etc. So those are the kind of the main documents that we're all aware of in the region, where we kind of use as a framework to undertake the analysis. So what was the main findings? I mean, we have a document that we finalized, and it's with the UNFPA for review at the moment. And so it details some of these findings and provide some indications going forward. But we've synthesized some of those main and key findings that's reflected on this slide. We found only 1 in 5 of the countries has a standalone policy on men involvement. So that's interesting, and we think even though there's been more work being done in the region, we think that's a deficit. The framing, gender binary and heterosexual normative framings and tendency to exclude men in all their diversity. We found, even though there's a mention of men and also women in SRH strategies, little acknowledgement for gender transformative interventions, which focus particularly on dealing with issues of inequality. Absence of disaggregated data. Data is important to be able to tailor interventions. Where we found men being mentioned, it was mostly within the kind of HIV space, particularly medical male circumcision. Less prominent was male sexual dysfunction, infertilities, reproductive cancers. We thought that was an area that was a blind spot in the policies. Protected silence on positive sexuality, messaging on sexuality, and mostly messaging had a negative connotation, focusing on risk and toxic aspects of masculinity. more focus we thought on could be a point on emphasizing men and boys in eliminating sexual and gender-based violence. So we think these points could be useful for policy and strategy deliberations going forward. Some promising terms, more countries are taking deliberate steps to articulate men as clients and involve them as partners, and we'd like to see a bigger push for advocates of social change, and concepts like male involvement, gender responsiveness, gender transformative interventions need to be defined and further operationalized. We think there's some conflation of terms here, and we need to be more specific in terms of the meaning and the intent. There's some promising practices on male support, psychosocial support for engaging in services, and I think that's really important and could be used as leverage for other interventions. So there is some useful and promising areas within these strategies. So pause for a moment on the policy analysis and look at some of the operational research we undertook in each of the countries. This was a situational assessment, and you could see that in each of the countries, we try to have sampling focused on the urban and rural areas, and we worked with partners and service organizations within each of these districts to help us engage with boys and men's decision makers and program implementers. And we also undertook some key informant interviews with government officials. So the sample size to date is in the survey has approached about 800 participants, and we'd like to realize 1,000 before the research is completed. In what follows, I want to provide you with a quick descriptive analysis of some of the key outcomes. We see that a high percentage of men engage in sex. Condom uses is inconsistent. We know a high percentage of our sample had symptoms of an STI. We're not aware of the status of the HIV status of their partner, and had some symptoms of mental health issues. Okay, intimate partner violence was an issue in the sample as well, and we found traditional gender roles was symptomatic of men in the sample, and engaging in intimate partner violence was of major concern in the study. I'm getting to my last slide in the next one. What we found in terms of services, barriers to services were around typical issues about male reticence in seeking and knowing about health services, health systems factors like time to access services, affordability, distrust of doctors, feeling disrespected. So kind of negative experiences engaging with the health system, and preferences for engaging with health services regarding convenience and confidentiality. So colleagues, this is my last slide. Some implications going forward. From the policy analysis, we think definitions of terms are really important when we think about policy work, and I think that there needs to be more emphasis on gender transformative interventions within the policy framing, biases and blind spots in policies, enabling diversity, promoting men as clients and partners and agents of social change are important, emphasizing positive sexuality. The predominant HIV focus in most of the engagements and within the realm of key populations, I think that the focus needs to be broader and need to engage SRH more broadly, as we've seen some areas of neglected services for men. We need better data to be able to tailor and contextualize interventions. I think that comes out clearly in many areas. A clear articulation between policy strategies and programs with dedicated monitoring mechanisms and budgets. I think there's a gap between policies and implementation. Again, not a unique finding. Dedicated male engagement programs are important to shift gender scripts and norms. Again, it's a key issue about norms, and this was mentioned earlier on in the introduction. Focus on psychosocial services is key and important. And I think as a general point for this analysis is that we need to kind of put more energies into building coalitions and fostering better synergies across sectors, academia, NGOs, development partners, civil society is important to religious organizations to engage men in SRH programming across the 3 areas, especially in light of the limited resources we have. Thank you, colleagues.
Thank you very much, Kay, for your presentation. That was very rich. We really appreciate you for taking your time to share with us your findings and the research in regards to men's health. And now I would like to open the floor for participants to ask questions in regards to Kay's presentation. Please feel free to request for the mic, or if you are not able to speak, just feel free to write your question and I'll be able to read it out. But just before I invite anyone to ask questions, maybe Kay, I have just one question for you in regards to programming. What are some of the programs that exist for men, and what are some of the gaps and opportunities that we foresee in space? Okay.
Thank you for that that important point. I think it's male programming, as you know, the policy analysis indicated, you know, and for good reasons, we've had male programming focus particularly on HIV, and that's been the history of programs in the region. But with it has, you know, there's a strength to that, and there's a weakness to that because we neglect other male SRH issues. But I think we need to capitalize on the strengths of the HIV programming, the focus on prevention, on treatment, on using VMMC as a vector of entry into the broader sexual and reproductive health space. There's less programming. There is examples and citations of interventions, community-based interventions on dealing with social norms and mitigating social norms, or working on social change, but it requires scale up. It's not sufficient scale up, and I think the gap between interventions and scale up is a conversation we need to have on how this occurs, and we don't have clear answers to that. I hope that kind of gives you a sense of the perspectives in relation to the point you made.
Yes, okay, thank you very much for your response. And at this point, I would like to invite anyone else to ask questions or concerns or suggestions as well, or inputs in regards to Kay's presentation, to unmute and ask questions. So I'll give 2 minutes, 1 minute actually. This is on first come, first serve. All right. Seems we don't have questions.
Sorry, can I please say something? Kay, that was a very great presentation. And you know, whilst you are presenting, you know, it's just going back to a lot of research that has been done. And again, you know, when it comes to men or men, young boys, you know, in terms of them going into, you know, clinics, like seeking health care, it's still a problem. And, you know, as much as there is this push to, you know, to kind of encourage them, you know, to get into such spaces, but the healthcare sector for many young men or men in general, it's still viewed as a feminine space. So how do we then move in really encouraging them, you know, to access such spaces where, you know, there seems to be a lot of barriers, you know, a lot of hindrances that, you know, prevent them from us accessing such spaces because of the many influences, you know. So how do we get there? How do we get into that, you know, that space, you know, that, you know, just to encourage them more to use such spaces? I think that is just that for me. Thank you.
Thank you very much, Nakekelwe. I hope I'm pronouncing your name well. Kay, do you have any response to that concern, or are you okay?
Yes, I think that's an excellent point, and I think, you know, we are searching for answers in that space on how do we bring men to, or how do we create demand for men to get to services. And then, I mean, the demand creation is the one part, and the other part is the accessibility of the services. And those are the two components that we should be focusing on. And it certainly is a challenge. And some insights from the data, if you just go back to the slide where I presented responses of men regarding services, and they mentioned things like convenient times, and certainly when I did a previous study for SADC on mobile populations at truck sites, for instance, focusing on a particular group of men who were truck drivers, convenience and time was a really important area. It's the slide that follows that. Yeah, that's the one. Yeah. Convenience was really an important point, but you also see confidentiality, non-judgmental behaviors of health service providers. And again, this is not new to us. We've been working in the HIV space for a long period, and we know these are issues that need to be addressed. Interestingly so, though, there's a component of masculinity and this kind of reticence about men and young men seeking services. You know, this notion of invulnerability. You know, I don't need to seek health services because things are fine. You know, if it ain't broke, don't fix it kind of attitude. And we need to kind of encourage men to get to these services, and possibly working with partners, working through social groups. We know that men have, rely on social groups for, in terms of their, you know, activities, in communities, etc. So those are some of my thoughts.
Thank you very much, Kay. Lizzie, I can see your hand up. Please,
Yeah,
proceed.
Yes, thank you. And I hope you can hear me clearly. I'm having a horrible connection, so I'll make it brief. In terms of the statistic, you said 1 in 5 countries have a standalone policies. The other countries, do they have maybe male involvement, like in other policies, that it's not standalone, or are these like non-existent? It would be good to like data.
Yes, thank you for making that point. You tend to find in most of the countries, engagement with men and boys is evident, but it's evident as part of a kind of integrated policy. either in the HIV space or more general within the SRH framing. And the point being made there was that the Ugandan case study was the only one which had a specific male engagement strategy and policy. So we thought that was important and as an exemplar of a good practice in the region, because it understood and it articulated where the focus should be for men and boys, and why men and boys should be are a neglected group, and where the focus should be in terms of the kind of the details and unpacking the policy. So we think, you know, if men and boys are mentioned as part of kind of gender policy, there's a tendency to blind spot some of the issues, or to ameliorate or dilute some of the areas for engagement and action. I hope that kind of addresses your question.
That is perfect. Just a second one before I lose connectivity.
Sure. Yes,
so
yes.
in terms of now, sorry. Just in terms of culture, I mean, we're talking about the Eastern and the Southern African countries. They have their own culture that comes into play, and we have policies when we're looking at it from a more medical perspective. I don't know whether during the research this came out clearly as one of the issues why male do not actually seek such kind of services. And if that was the case, would there some sort of a solution to that kind of a barrier in terms of their services and how they can seek without, you know, going against their culture, or maybe incorporating culture and the services in such a way that, you know, it shows that we really do need our men involved in such kind of discussion. And I mean, we need them to be healthy. And that means they need to sort and seek out all these health services that, you know, some would look at it like, you know, not necessarily he's a man. He can just, you know, like brush through all these health issues and all that. Was there any instance where culture kind of came up as a hindrance to them accessing these services?
Again, Lizzie, that's an interesting point, and we didn't focus in the surveys. The main part of the focus was on, you know, the global package of services and getting a sense of whether men understood or were aware, as a simpler term, of these services, that could be potentially available, and what actually was available, and what were the barriers in seeking those services. We are presently analyzing the qualitative data, and I would guess that issues on culture would come to the fore. I see Caroline, who's on the call as well, may provide some perspectives on some of the nuances coming through in the qualitative data analysis. But I think it's an important issue, the social and cultural. We certainly understand some of the social and gender kind of barriers, and we've seen that in the quantitative analysis, the inequitable attitudes, the traditional gender scripts, and how that links to intimate partner violence. That seems to be a main area of concern in terms of men and masculinities. But possibly, Caroline, you want to talk a bit about the culture part, if you don't mind.
Yes, no, sure. Thank you, Kay. Indeed, Lizzie, that cultural aspect came out very prominently in the analysis or the data that we have from the 5 countries. And then particularly in how boys are viewing their own role as a man in a relationship and what they were told to be or to be acting. For instance, you know, bringing their girlfriends to the clinic was a definite no-no. That would be culturally unacceptable. You wouldn't bring your girlfriend or multiple girlfriends to the clinic. So it's a very important insight that the focus group discussions are giving us, that actually the boys who are still exploring relationships will not be coming to the clinic for STI screening or couple counseling until they are married. So the question then is, what are we going to do with those findings? How can we adapt our services or speak to these boys in terms of how important it is that they are actually coming to the services or make use of outreach facilities in that. So there's a culture, it's the initiation. I think another big finding was the gap between sexual education in the home, which is culturally unacceptable as well. And as you very well know, I think it's the aunties and the uncles that are supposed to provide some insights, but definitely not the parents. So there's a big gap as well in terms of information around sexuality, around sexual health and reproductive health, which really poses a barrier to young boys to be able to identify a problem in the first place and then feel that they need to go somewhere and not rely on secondhand or third-hand information that is possibly not evidence-based or very helpful to them. So there's a range of cultural aspects that are coming out and that are really important to further unpack, and then to see how does that help us to improve services, but particularly also our relations with boys and young men in the programs. You know, what is the sort of message that speaks to them, that actually addresses their needs? Thank you.
Thank you, Caroline.
Thank you so much, Caroline and Kay. Thank you for your question as well, Lizzie. Sinekele Kekelwe says that it's also very important for us to look at social cultural influence in these issues. I totally agree with you. Also, Rushiri asks if it's possible for learning purposes to also have access to the findings. So maybe Kay will advise us on that.
Can you repeat that question again, please?
Rushiri asks if it's possible for the purposes of learning to have access to the findings, to the research findings.
Oh, yes. Okay. Absolutely.
Okay, cool.
Yeah. When we've completed with the findings, we will circulate this in various formats, and then it's a conversation we'll have with UNFPA, but certainly we can make these findings more visible to multiple audiences. Thank you.
Okay, thank you very much. Lizzie, you have something before I give
Sorry. Just out of curiosity, because as I mentioned earlier on, I had a bad network. Maybe this was already mentioned. Just out of curiosity, when you're doing your studies, I know there's a meeting for ESSA that I attended, and we had a side session where everybody was like, hey, wait, when we're talking about adolescents, in terms of boys, we cannot start at 10 years old, or if it's girls, we cannot start at 12, because we have maybe 9 or 10 who have started their menstrual and all that. So in terms of men and boys, and we're talking about this reproductive services, is there like an age you're looking at? Because I don't think most parents will be comfortable with an underage being told about, you know, the services that are available that they can access, unless they feel like this is the right age for my son to start, you know, talking or accessing such kind of services. So I just needed to know real quick in terms of your research. Maybe you mentioned it, I didn't get it. Is there an age you're working at so that you can, you know, culturally, I'll bring that again, work within the boundaries where, okay, so this is where they start dating, or this is where they start, you know, having sex, and this is where we need to bring the services in and make them, you know, available for them. Is there like an age you're working with?
Yeah. Again, a good question. If you look at some of the regional policies, and I'm thinking about South Africa here, you can access HIV testing if you 12 years. It's in the current policy, and there's mention of being, you know, if you're 10 years and above, to be aware of sexual and reproductive health services. So, but countries differ on this, and they have different you know, upper thresholds. I think it's important. Age is used as a proxy for developmental status, but it doesn't always align. what I'm saying is that one has to, the development maturity of the child is not always reflected in the age. So one needs to have a more in-depth kind of analysis or conversation about mental capacity to understand issues as a prerequisite for engagement and engage in relation to developmental maturity. And I think that may be a more appropriate way to engage with sexual and reproductive health services. But that obviously requires trained personnel as well.
Thank you very much, Kate. Thank you so much, Ali, for bringing that up. And even Aaron Sanders says that sometimes I think how to even start a conversation by the parent is even very problematic. So thank you very much, Kay, for your presentation. I really appreciate your time. So at this point, with the interest of time, I would like to invite Sally Adungo to give us a presentation. Sally.
Thank you so much, Doris. So I hope you can hear me.
Yes, proceed. We can hear you. Thank you.
Okay, thank you. So my name is Sally Odunga, and I'm going to take you through our scoping review findings on male engagement in programs addressing violence against women and girls and harmful practices in Africa. I'm really glad that this discussion comes after the presentation from Prof, where there have been questions on social norms, how they affect how males are being engaged in the SRHR services. So for this particular presentation, our focus was on violence, on ending violence against women and girls. Next slide, please. So the presentation outline, my presentation will be in 3 parts, where we'll have the background, the methods, and then I'll finish up with the findings and the implications. So why did we decide to conduct a scoping review on how men can be engaged to end violence against women and girls? First of all, it's important to note that violence against women and girls and harmful practices, it's a violation of human rights. And when we're talking about violence against women and girls, here we refer to issues such as intimate partner violence, non-intimate partner violence, violence against children, etc. The list is not exhaustive. And when we are talking, back please. And when we're talking about harmful practices, here we refer to issues such as female genital mutilation or cutting and child marriage, etc. As I've mentioned before, the list is not exhaustive. This is just but some of the key indicators of violence against women and girls, as well as harmful practices. So statistically, please go back. Statistically, WHO estimates that 1 in 3 women have experienced physical and or sexual intimate or non-intimate partner violence. You can see how that is a large number of women who have experienced such kind of incidences. And also, if you look at the UNICEF report of 2021, it mentions that at least 200 million women have undergone female genital mutilation or cutting. Last but not least, when you're talking about child marriage, in that same report, it has been reported that of the 20 to 24-year-olds who have been married before 18 years, 20% were married due to, it was child marriage. So it's important to also note that these statistics differ regionally, nationally, and subnationally. And for this particular presentation, we are now going to focus on the statistics in the African context. So when we start looking at IPV as an indicator, a study conducted by WADO indicated that about 25% of girls aged between 15 to 24 years in 27 countries where they conducted a systematic review, they found that 25% have already experienced IPV. Izugbara also in his study, he reported that for women aged between 15 to 49 years living in the urban areas, they have also been able to experience IPV. When we move to the FGM indicator, it has been reported from the UNICEF report that FGM is more prevalent in Africa among 15 to 49 year olds, and it is worrying to note that over 80% in some countries report that there's FGM that is taking place in their countries, such countries such as Somali. But while there are countries that have higher percentages of FGM happening in their countries, there are countries that FGM, the number of cases reported is even less than 10%, such countries such as Uganda. When we now look at child marriage, from the literature, it has been indicated that child marriage is highly prevalent in West and Central Africa, but this does not mean that other countries do not have child marriage, but the prevalence is relatively high in West and Central Africa. A study from Yaya et al., they indicated that Niger, for example, 82% they report child marriage, and when you look at Rwanda, only 17% was there were reports of child marriage in Rwanda, only 17%. Next slide, please. So it has been noted that, and I remember from the discussion earlier, that social, cultural and gender norms play a big part in enabling violence against women and girls and harmful practices. And when we're talking about inequitable socio-cultural gender norms, here we are talking about norms that relegate women to inferior positions. We are also talking about norms that allow an equal power distribution between men and women. Here we are also talking about negative masculinity that focus on dominance on women. So when you factor in all these issues that I'm talking about, you would see how they play a big part in enabling violence against women and girls and harmful practices. In the recent times, there's been a global push to address these inequitable norms, and one of the recommendations that have been advanced is that there should be engagement of men and boys in programs to enable the social agenda norms change to eliminate violence against women and girls. However, there are limited programs that are focused on men engagement in ending violence against women and girls. And from the programs that have been reviewed, most of the programs they have not reviewed whether the programs have been effective in eliminating violence against women and girls. So it's against this backdrop that APHRC consortium that consists of African Population and Health Research Center, Population Council Kenya, and EANNASO conducted a scoping review under the Spotlight Initiative project. Next slide, please. So our scoping review aimed at answering 3 questions. We wanted to find out what are the social norms that perpetuate violence against women and girls and harmful practices. The second question that we wanted to answer was what are the barriers and facilitators of male engagement in ending violence against women and girls? Last but not least, we were also interested in knowing the programs that have engaged males to promote social norms change in violence against women, in ending violence against women and girls and harmful practices. Next slide, please. So our methodology, our review was guided by the PICO framework that looks at the population, interventions, comparison, outcome, and time. So that's what our review was guided with. As part of our search terms, the search terms varied by research question as indicated, and for each databases we used various search terms. However, the 3 components in our search terms were violence against women and girls, social norms, and sub-Saharan Africa. So in our searches, we did electronic search. We also did hand searches. So in our electronic search, we looked at PubMed, Scopus, Science Direct, among others, for published peer-reviewed journal articles. And we also complemented this electronic search with hand searches. So for a full text review, we were able to include 82 articles. Out of the 82, we excluded 20, and finally, we remained with 62 studies, 62 articles that we were able to include in our final review. Next slide, please. So I'm going to share the key findings while answering to each research question that I'd highlighted before. So findings on social norms that perpetuate violence against women and girls. Indeed, social norms we found that social norms are intertwined with gender, cultural, and religious norms. They have a link. Social norms linked to gender, cultural, and religious norms. And another key finding on the social norms that perpetuate violence against women and girls was that gender roles and beliefs about the women's status, which most often is that they are inferior, in society sustain such norms. In these societies where power and authority is bestowed to men, enables men to think that it is okay to perpetuate violence against women and girls because of the belief that women are inferior in the society. Again, from the studies reviewed, we found that some men engage in perpetuating violence against women and girls because that's a way of them reinforcing their masculinity. There's also the aspect of social cultural expectations, for example, for child marriage, as well as violence against women and violence against women and girls. Some men engage in this because of the social cultural expectation that it is normal to do so. Again, there's an issue of moral arguments that came up in the studies that we reviewed, that it is that beating your wife is a sign of love in a relationship, and therefore it is not something that should be condemned. Actually, that it's something that should be accepted because that's a clear indication that your husband or your partner or your lover really loves you. Again, on the issue of marriageability, for some engaging in female genital mutilation or cutting enhances marriageability in some communities. So that is the reason why they engage in female genital mutilation or cutting. Then the issue of child marriage, the argument here was that the reason why some communities engage in child marriage is because they would want the ladies or the young children to get married when they're virgins and when they're pure, hence the reason why they engage in child marriage. Another finding was that the cultural beliefs here, or cultural norms here, we are talking about the rite of passage. Some communities engage in acts such as female genital mutilation because it's their cultural belief that one should be done, and they do not have any other reason why they do so. So that one also enhances such kind of harmful practices. Last but not least, we also have religious beliefs. As I said, the social norms intertwine with gender, cultural, and religious norms. Under religious beliefs or norms, in some religion, the issue of dominance of men on women is seen as a will of God and often misinterpreted. And this allows for some men to engage in violence or treat women as inferior because, according to the understanding or from their religious perspective, this is a will of God. Next. Now, moving away from the social norms, so we were also interested in knowing the programs that have engaged men and boys to promote social norms change in ending violence against women and girls. So out of the 62 studies that we had indicated, 12 of the studies were able to mention some of the interventions that have been there. So the interventions included, I will just mention a few, not all of them. So there was an intervention in various countries. So there's one from Ethiopia known as Unite for a Better Life. We have Empower Kenya, we have Communities Care Program Somalia, we have Learning Center Initiative Uganda, Sonke South Africa, Cash Plus Ujana Salama Tanzania, Bande Bereho, Rwanda. Those are just but a few interventions that we were able to pick from the included articles. So what were the effect of these interventions? This was an interesting finding that majority of the interventions led to changing unequal gender beliefs and attitudes. However, it's important to note that while majority led to the change in unequal gender beliefs and attitudes, only few led to reduction in IPV, and that IPV is highly experienced. So some of the interventions that were successful in changing unequal gender beliefs and attitudes included Communities Care Program, the one that I mentioned in Somalia. There was Learning Center Initiative in Uganda, Unite for a Better Life Ethiopia, among others. I did not include all the interventions that were able to achieve this effect. And some of the ways they were able to do this were to engage in house chores. Some of these small issues that people think are small issues also contribute to violence against these women and girls in homesteads. Also, they were able to believe that women can also be involved in decision-making in the households, and this was able to reduce violence incidents in these households. As earlier mentioned, that most of the interventions were able to lead to a change in unequal gender beliefs and attitudes. These are not the norms. They were only able to change unequal gender beliefs and attitudes, but not norms. Then we have few that led to reduction in IPV. The example of such interventions were I Empower, reduction of gender-based violence against women and girls from Côte d'Ivoire. So one of the reason why one of the reasons that was given why these interventions may have not led to reduction in IPV was that the interventions were assessed. There was a short timeline to assess the impact, hence they did not have adequate time to assess whether there was a reduction in IPV or not. Again, one of the issues that came up that is the rigidity in behavior change. It's often difficult to change. You can change somebody's beliefs, but really changing their behavior after doing something for over a period of time, they develop it as normalcy, and so it becomes a challenge to just change it over a short period of time. It takes time for that change to be achieved. Again, the intervention design, how the interventions were designed also contributed to how the effect that these interventions would be able to achieve. Next slide, please. So apart from the programs that we've mentioned, because earlier I've mentioned the social norms, I now mentioned the interventions that were there. We were also keen to find out the facilitators and barriers of male engagement in ending violence against women and girls. So I'll just highlight some of the facilitators and the barriers. So facilitators was economic empowerment initiatives. When both men and women are provided with financial initiatives and they're able to be empowered economically, it reduces the likelihood of them engaging in violence against women and girls and harmful practices. Again, engaging men and their partners in participatory small group sessions of critical reflection and dialogue was very important, that we not only engage men, but also engage them with their partners and help and let them have conversations on how best they can be able to tackle this issue of violence against women and girls. Again, programs that enhance boys and men's lives, inclusive of and responsive to diversities among men, taking into mind that it's not a one blanket intervention, that the programs should be able to look at diversity among men, and also to address social and structural determinants of gender inequalities in different contexts. Also, another facilitator was that creating men models within communities was also demonstrated that it is able to help in achieving behavioral change. Last but not least, conducting community mobilization and sensitization initiatives also helps in engaging men in ending violence against women and girls. Having mentioned the facilitators, I'll now move to the barriers. So barriers, still the issue of social norms come into play. The inequitable social, cultural and gender norms, as I said, these norms are the ones that enabled men to give men the ability to, for lack of a better word, to dominate over women, makes it difficult to have the to engage them in ending violence against women and girls, because these are the norms that they have grown with. This is the environment that they live in, and they think this is the right thing to do, and it's okay because it's within their environmental context. Secondly, economic hardship, unemployment, and migration. This also, without proper economic empowerment, it leads to some frustration that also is reflected in the various households, and hence leading to IPV. Also, some of the interventions that were initiated, some of the participants were not even aware of the interventions, therefore implying that the intervention should be able to be inclusive so that the effect is achieved in large scale. Then limited time allocated to the programs. The programs, if changes to be seen over time, then there should be a considerable amount of time to be able to see how the intervention works among the selected group of people, and see how best the interventions can be enhanced and can be sustained over time. Then lack of focus on addressing the perpetration. The interventions the structure of the interventions, how they're designed, some of the interventions do not focus on addressing perpetration. This leads to inability to achieve the end goal of trying to eliminate violence against women and girls through male engagement. Then lack of understanding on what supports social norms within different contexts. As I had mentioned, social norms apply in different contexts, hence the intervention should be able to look at social norms within different contexts and apply the interventions that specifically suit a different context. Then social pressure and discomfort among men. Again, it is not easy if you come from a society that allows certain behaviors, or certain behaviors are acceptable, because when you're trying to get out of that situation and you live in such an environment, it makes it difficult for men who wants to act as advocates of change to be able to advocate for ending violence against women and girls. Next slide, please. So having talked about the social norms that perpetuate violence against women and girls, talked about the interventions, and last but not least, talked about the facilitators and barriers, I would like now to conclude with some of the recommendations and the conclusion that we had based on our scoping review. And one of the key recommendations was that there should be a shift in how programs approach male engagement. Indeed, the interventions should go beyond focusing on individual factors and encompass a multisectoral approach, taking into consideration structural and systemic factors that propagate violence against women and girls and harmful practices. Indeed, changing an individual without changing the ecosystem in which they live in has minimum effects, hence the need to embrace a multisectoral approach. And when we're talking about multisectoral approach to address violence against women and girls, here we are referring to focusing on different levels of the ecosystem. That is, we're looking at from the individual to the macro systems, rather than changing individual behaviors alone. Another recommendation is that interventions should be initiated at an early age when gendered behaviors are being learned and internalized. Next slide, please. So for our critical policy and program gaps that we noticed was that violence against women and girls is prevalent even in context where policies and programs geared towards eliminating the practices are in place. Then there's need to be looked into. There's need.
Especially when you don't have
Melvin, kindly mute yourself. Thank you.
Baloli, can you please mute yourself?
Thank you.
Please, Sally, proceed.
Okay. Then there's need to relook into ways in which policies and frameworks on eliminating violence against women and girls can be effectively implemented. And I think I've come the conclusion of my presentation. Next slide. Yeah, that was it. Thank you so much for listening to me. Thank you, Doris, over to you.
Thank you very much, Sally, for your rich presentation. Sorry for the inconvenience and for the person who was unmute. At this point, I would love to invite all of us to ask their questions or give their suggestions or any pointers that they might have picked from Sally's presentation. And welcome. Feel free to unmute and or at least write your question in the chat box. Yes, Carol. Proceed, Carol.
Yes, thank you for this presentation around violence against women. I was looking at your recommendations, and I think perhaps I do understand the suggestion to expand to a broader view on the problem, but I still believe that individual behavioral interventions are very critical. Particularly in households where this is happening every day. So I think it's a two-pronged approach that you should be suggesting. I'm not sure if maybe because the way it was written up, that was overlooked, but I would still advocate a lot for individual behavioral interventions as well for those women who are within that situation. So maybe presenter can explain a little bit more.
Thank you, Caroline. I'm getting my name right. Indeed, what you're saying is very true. Maybe the way it was indicated is a bit different. What we are saying is that the individual factors are okay, but we are saying that we should not only focus on individual factors, but also focus on the systemic and structural factors. That indeed the individual factors are there, and most interventions were focusing on individual factors. However, we are also acknowledging that these men also live in a society and in an ecosystem whereby once some of the factors have been addressed, they still go back to the societies where they live in, and some of these issues such as the norms and the heritage and the traditions and the beliefs are still there. So what we are actually recommending is that the focus should be multi-sectoral and should focus both on the individual, structural, and the systemic factors. We are not saying that we should exclude individual factors, but we are saying that we should focus on individual, structural, and the systemic factors. I hope I've been clear.
Okay, yes, thank you.
Okay.
Yes, Kay, your hand is up.
I thank Sally. That was a very useful presentation, and I think we speaking the same language from the research that we are doing and your analysis. The key focuses seems to be, and where we need to kind of coordinate our work is on environmental, structural, and social barriers, and I guess from the evidence that you present, where the challenges are and where the science is at, the science has shown that we can develop interventions at a small scale, at a community base, as I pointed out earlier, which shows some impacts, some positive impacts, but it's over a short term. I mean, the science is complicated for a number of reasons in terms of the measurements and measuring effects and longitudinal effects, etc. But we have demonstrated through, like, for instance, the work by Rachel Jukes, the interventions, the one-man can interventions, the work by Sonke Gender Justice on conscientization approaches, etc. That there is a kind of a conceptual way to engage with men. The problem, I think, is getting it from that intervention and small scale kind of efforts into a larger scale programming effect. And here, for me, and as you point out, I mean, we should bring in and we should include economic elements, financial literacy components, elements that kind of engage men on a broader basis and integrate them into related sectors in society. And I think that's the bigger challenge. If we focus interventions and they're too kind of boxed in their approaches, we lose the kind of the larger connectivities, then it's not sustainable. But I'd like to hear what you think about those views. Thank you.
Thank you, Prof. For some reason, I was not able to pick the exact comment that you want me to address, but I would understand the aspect that you're mentioning, that some interventions on large scale, on small scale have been doing well, but now having to move the interventions from the small scale to large scale to be able to achieve even a bigger impact is quite a challenge. But indeed, looking at the barriers and facilitators, you could see clearly what needs to be done as far as the facilitators is concerned. Most of the time, violence against women and girls is focused on the health aspect of it. There's failure to acknowledge that there's economic component of it. And sometimes if you get to hear the reasons why some of these households engage in violence against but even with their wives, is because of frustration, economic frustration, that they are unable to provide as men. And I think for me, it also still boils down to the societal norms, that men, for some reason, believe that they should be able to be the sole the main provider, they should be able to provide for their family. So in the event that they are unable to do this, one way that they're able to reinforce that they're still the head of those households is by showing that the authority. And some of the time they do this through beating their wives, and this is not okay. So really, when looking at violence against women and girls, it's not only a health issue, it's also an economic issue and a development issue. Therefore, it should be looked into in those three perspectives and not only as a health issue. Please, if there's something you wanted me to comment on and I've not touched on, please, I would be happy to respond to.
Thank you very much, Sally and Kay, for your question. And Lizzie says, I think this was from the previous presenters, and she says that, and the concept part kicks in, how do we start to talk? How do we starting to talk about the services in school with underage boys? Another comment was from Isabel Just. Yes, I'll get back to you, Sinakele. Isabella Just says that on the topic of how parents or other caregivers, family members can have discussions about sexuality and sexual health with boys and girls. This might be of use, and she has shared with us a link from UNFPA that you can check out. I believe that the resource will be very helpful. And then we have a question from Jude, and he asks, what of the influence of the youth space that can be used as safe spaces for provisions of health services and information? I believe this question is directed to Sally. So maybe Sally, I can give you an opportunity, and then I take the question from United. Thank you.
Thank you, Jude. I think this is a good idea. The influence of youth space that can be used as safe spaces. Can you ask this question, please? Maybe I don't understand it very well. Is it a suggestion?
Jude, maybe you can ask it so that it comes out clearly. Jude? Okay, let me just read what he has written. Okay, cool.
Sawa, ngoja basi hiyo sheet naiongezea hapo ambapo sasa tutakuwa tuna
Fabiola, kindly mute yourself. Thank you. Okay, let me just what it has written. What of the influence of the youth space that can be used as safe spaces for provisions of health services and information? Maybe this could be a suggestion, Sally.
Yes, I believe it was a suggestion. I've read it and I thought it was a suggestion, not unless.
Okay.
Yeah. And it is a good suggestion, actually. They're using the youth space to provide health services and information, especially for boys and young men. This would be a good suggestion.
Thank you very much, Sally, for that clarity. And now I would like to give Sinekekele an opportunity to ask a question before I give back the mic.
Okay. It's not necessarily a question. It's just a comment for us all, you know, because I think it's something that I engage with myself and also, you know, the males around me in terms of the consideration of the vulnerabilities of men as well, you know, because in whatever, you know, interventions are put in place, you know, like how then do we get to a point of considering also the vulnerabilities of men in our interventions, you know, in enabling them to also speak out? Because, you know, even when you now look at social media spaces, you see that there is an outcry among men, you know, for them to be considered as well in policy formulation, in interventions that are put in place as well, for them to also be engaged and for them also to be considered in whatever, you know, is done in the implementation of interventions, you know, because it would be of disadvantage, you know, if, you know, every time when we speak on anything, you know, focusing on men, it's only focusing on the negative, and also just even promoting, you know, the positive behaviors or that are seen, because, you know, as much as yes, you know, there is harmful behavior and whatnot, but even when you go into literature, you see that, you know what, there is a shift, you know, in terms of their behaviors, but most importantly, their vulnerability. How do we capture that? How do we enable them to speak out? How do we engage them? Yeah, that is just always just a conversation that I always have with the self, and I thought I should just maybe just say it out loud. Thank you.
Thank you very much, Sinakekelwe. I hope I'm pronouncing your name right. And at this point, allow me to kindly give back the mic to Richard Derry so that he can give us the last or the final remarks as we've come to the end of this conversation. Thank you everyone for joining the conversation today. Please let's not end this conversation here, rather let's spread out the wings and also continue sharing this information and research findings with other people, even in our society, and even in our other spaces. Thank you very much. My name is
Good afternoon, everyone, and thank you very much to Doris for her excellent facilitation of this discussion, and also to our two presenters, Sally and Kay Govender, for their excellent presentations. I think there's a couple of key messages coming away from this session today. First of all, I think there's a recognition that we really need to look at how do we fast track the development of policies and strategies that deal with issues around men and boys. And I think that came through across both presentations quite clearly. The second thing is we need to look at programs and services. And when we're looking at programs, I think what came through very clearly in Sally's presentation is the need to really look at evidence-based approaches, but without losing innovation. I think there's always a danger when we focus too much on evidence that we lose innovation. So we need to strike a balance between these two elements. But also, I think coming through very clearly from the presentations, actually from both, is the need for us to adopt a broader perspective around programming with men and boys. And I think the social ecology model that recognizes that the individual lives within a broader structural and social and community environment is a very useful framework for us to use as we start thinking about how do we design programs and interventions for men and boys. In terms of services, I think, I think it's a challenge for all of us around how do we increase accessibility for services and how do we make services more available for men and health, for men and boys. But we also know that especially when it comes to gender-based violence, that we have a lack of psychosocial services across the continent. And a lot of men and boys who are perpetrators require very intensive psychosocial support services that we do not have available. And so we have to start thinking around innovative approaches around how we can either work with community healthcare workers or skill up community healthcare workers to also incorporate mental health a lot more into the programming that looks at men and boys. And I agree with some of the discussants around the need for us also to look at the demand side. How do we generate demand for men and boys to take up the services that are there? And many of them are not taking it up. Social norms definitely dominated this conversation, and I think it's an issue that we need to continue working on and continue looking at. And I'd really like to thank Sally and also Kay, because there were a couple of really good points in both presentations around social norms and how to measure social norms. And I think what we saw coming through was definitely issues around masculinity, the linkages between to moral, gender, culture, religion, but also a lack of knowledge and also men's attitudes in general. And so I think we need to think a little bit more holistically. But I think one of the key takeaways that I took from Sally's presentation in particular is behavior change takes time. And I think when we think about time, then we also need to think, are we intervening at the right point in time? Because have we started thinking about how do we use early childhood development centers or early childhood programs to really work with very young boys around addressing some of these male norms and attitudes? Because I'm under the impression that many of these attitudes and norms are actually formed at a very young age. And so we almost need to intervene a lot earlier and a lot sooner. So I think we need to look at early childhood development programs as an opportunity to also look at addressing issues around young boys in particular. But I think one of the key things that I took away from this presentation is also the need for partnerships and very strong partnerships that work together around issues around men and boys. And I think what we have on this call today is the beginning of a partnership that can discuss and that can look at how do we address men and boys. Just looking at some of the participants. We got participants from Kenya, Mozambique, Eswatini, South Africa, South Sudan, Lesotho, Liberia. So I think it's important for us to continue this conversation across the continent around how we deal with men and boys. Finally, I come to the easy part of my closing remarks, which is just to really give a shout out. And Jude, I don't know where you are. I see your name there. But just to give a shout out to Jude from MenEngage, who has really helped pull together this, this webinar today, Marietta from UNAIDS, Doris and Glory from EANNASO, Kay from UKZN, APHRC, and also all our colleagues from UNFPA and the other UN agencies, just to thank everyone that has worked behind the scenes to really make this webinar a great success. And if I may, on that note, wish you all a great weekend ahead. Thank you for the time. I know it's a Friday afternoon, so please do enjoy the weekend. Thank you for giving your time and for being with us this afternoon. Thank you. Bye.
Bye, everyone.
Thanks very much. Thanks very much, Richard, and enjoy your weekend, everyone.
Thank you.
Bye-bye.
Thank you.
Thank you all. Thank you. Enjoy your weekend. Bye now. For now.
Thank you.